So good evening and thank you all for joining us today. We welcome you to the General Club today, up to date with updates, organized by the Haryana chapter ISAR. Now we present to you Cecilia M with the ideal formulation of myoinositol and D-chiroinositol to restore ovulation. We have Divatron SR, which contains 20 mg micronized digosterone tablets to improve compliance and enhance outcomes. And we have Lycored M, tablets of natural lycopene. So, with a warm and hearty welcome to all the esteemed faculties and attendees. Please note this webinar is streaming live on Facebook and the link has been shared in the chat box. Now, we invite Dr. Jyoti Haryana ISAR and Director Roots IVF at JJ Institute of Medical Services, Bhartogad, to initiate the program. Over to you, ma'am.
Thank you so much. Thank you, Jackson Paul. Thank you, Nimisha, for the platform. And on behalf of ISAR Haryana, I invite you all to this episode of Up to Date with Updates. This is 16th episode that we are doing. And we at ISAR Haryana constantly, with our tagline of Prayas Evam Vistar, continue to do such sort of activities at least monthly. And these are all with the blessings and with the support of our national president, Dr. Amit Patki sir, and secretary, Dr. Asha Bakshi ma'am. And also we have our think tanks of ISAR, Dr. Nandita Pashetkar ma'am, who has been the immediate past president, Dr. Sunita Tendulkar, the president-elect, Dr. Madhuri Patil and Dr. Sujata Kar, the vice presidents, and Dr. Charu Joshi, the chairman for embryology, with Dr. Keshav Malhotra, vice chairman for embryology. So these are the think tanks who are always there with us, supporting us, motivating us, guiding us through all such sort of activities which we are doing under the umbrella of ISAR Haryana. And with the team ISAR Haryana, with the secretary, Dr. Meenu Handa, the clinical secretary, Dr. Manju Dagar, and treasurer, Dr. Lakshmi Goyal, we bring to you this episode of Up to Date with Updates. And we have two wonderful speakers today, and we have an expert from IFS. And our MOC today is Dr. Lakshmi Goyal, our treasurer of ISAR Haryana. So today she would be starting with the proceedings. I invite Dr. Lakshmi to do the needful. Dr. Lakshmi is a consultant at Cloudnine, Faridabad. She has received Young Talent Award in Infertility by the National ISAR President, and she has actively participated as in the faculty as in FOXY accredited infertility courses and in many national international conferences. So over to you, Dr. Lakshmi, for the scientific part.
Thank you. Thank you so much, Dr. Jyoti. So, with the able guidance of Dr. Jyoti, who is our chairperson of Haryana ISAR, we will move forward to today's up-to-date session. We have two articles. Article 1 is the special consideration in assisted reproductive technology for patients with cardiovascular disease. And the second article is assisted hatching decreases pregnancy outcome in vitrified donor oocytes. So we have two presenters for these articles. But before the presenter, I would like to introduce our expert, Dr. Shalu Gupta. She's a renowned IVF specialist, and she's a clinical director at Cloudnine Hospital, Gurugram. Ma'am is a clinical director of Cloudnine Hospital, Gurugram. Her areas of interest are poor ovarian reserve, recurrent implantation failure, and PCOS. She's a founder member Fertility Preservation Society. She has presented many papers and has multiple publications in various journals and books. She's a past co-convener for SIS POR, and she's an executive member of Haryana IFS chapter. So we are all very delighted to have Shalu ma'am with us. With this, we will go on to our first presenter. First presenter is Dr. Charu Taneja. Okay, she's a fellow of reproductive medicine at Cloudnine Hospital, Faridabad, and she has done her senior residency in ESI Medical College from Faridabad, and she has done research and publications, and she has had many awards and achievements. So with this, we will go to the first presentation, and the first presentation will be by Dr. Charu. Over to you, Dr. Charu. Yeah.
Thank you so much, ma'am. Good afternoon, everyone. Today, we'd like to have a discussion on this paper, which is Special Considerations in Assisted Reproductive Technology for Patients with Cardiovascular Disease. It was recently published in August 2025. Why do we need to study this paper? The most important points are we are having an increased survival into reproductive age for congenital heart disease patients because of new treatment guidelines, and people are delaying their childbearing. So we are having more patients with acquired CVD, and also CVD complicates 1 to 4% of pregnancies. So we need to know what is to be done if a patient with CVD comes to us for ART. So why this matters? Because infertility affects 1 in 6 worldwide, and it will not discriminate CVD patients. Fertility preservation before worsening of condition is required for many patients. We can offer genetic parenthood through gestational carrier. PGT-M can be offered if heart disease of the patient is having monogenic inheritance, and we can also offer donor oocytes and gestational carrier for the patients who cannot afford to have a pregnancy. So what will be the objectives of review in this paper? We need to characterize CVD in ART patients. We need to outline pre-ART evaluation and risk stratification. And also, this paper provides evidence-based ART and IVF guidance. So first of all, this paper outlines the spectrum of various cardiovascular diseases and terminology as congenital heart disease, valvular diseases, cardiomyopathies, aortopathies, arrhythmias, coronary artery disease, and in heart transplant recipients. So if a patient comes to us who is having CVD and wants a pre-ART evaluation, first of all, we need to know that we need a multidisciplinary team for that patient, which includes a reproductive endocrinologist, cardiologist, maternal and fetal medicine specialist, and an anesthesia person. We should assess the fertility goal of that patient and what are the cardiac risks. We need to evaluate we need to have a full cardiac evaluation with echo, stress testing, ECG, and other testing. And we need to score that patient with Karpreg score or Zahara score. And we also have a MWHO scoring so that we can prognosticate the patient. And and we should optimize the cardiac status of the patient before giving her ART. So this is the MWHO scoring. In this, class 1 is having small or mild lesions. Class 2 has unoperated ASD or VSDs. Some are classified as 2 to 3, which have mild LV impairment, that is ejection fraction more than 45%. The class 3 has moderate LV impairment, that is ejection fraction 30 to 45%. And class 4, in which the pregnancy is contraindicated, it has severe ventricular dysfunction, that is ejection fraction of less than 30%, or we can say NYHA 3 and 4 patients. So what is the predicted risk of cardiac event in all of them? Class 1 has a risk of 2 to 5%. Class 2 has a risk of 6 to 10%. Class 2 to 3 has a risk of 11 to 19%. Class 3 has a risk of 20 to 27%. And Class 4 has a risk of more than 27%. So these are the tables showing the diseases in which pregnancy and IVF are acceptable. The second table shows pregnancy is significantly high risk, but IVF is acceptable. And third is most important, pregnancy is contraindicated and IVF is also high risk. So if a patient comes with these conditions like Marfan syndrome with dilatation of more than 40 mm, or pulmonary artery hypertension, or severe or aortic coarctation, or severe aortic dilatation, severe MS, severe symptomatic aortic stenosis, or ejection fraction of less than 30%, or vascular Ehlers-Danlos syndrome, the pregnancy is absolutely contraindicated in these patients. So we have to offer them gestational carriers. So as already told, MWHO class 1 to 2 is generally safe for ART in pregnancy. MWHO 2 and 3 is moderate to high risk. ART is possible, but with caution. We should prognosticate the patient earlier only. WHO 4, the pregnancy is contraindicated and gestational carrier should be offered to the patient. Also, we have Carpric 2 and Zahara scoring for the patients. Zahara is only for congenital heart diseases and Carpric 2 is for all other patients. So in Carpric 2, if a patient is having prior cardiac event or arrhythmias, she has a baseline NYHA classification of 3 or 4 or cyanosis, or she is having a mechanical valve. We give her a point of 3. She is having ventricular dysfunction, high risk left-sided valve disease, pulmonary artery hypertension, coronary artery disease, or high-risk aortopathies, the point is 2. And earlier, no prior cardiac intervention was done, the point is 1. So if she is having 0 to 1 point, the risk of cardiac event is 5%. If she had 2 points, 10%, 3 points, 15%, 4 points, 22%, and more than 4 points, 41% risk is there. So coming to the specific guidelines for IVF and ovarian stimulation as advised by this paper, in this, as we know, the ovarian stimulation has some cardiovascular shifts like reduction in left ventricular ejection fraction and increase in preload. So we need to take care for this. And also OHSS is generally also not acceptable, but in the patients of CVD, it is life-threatening. So we have to avoid it at any cost. We have to prefer GnRH antagonist protocols and agonist trigger for this so that OHSS can be prevented. Also, it suggests that OCPs should be avoided for cycle rescheduling and progesterone-only pills can be used. And single embryo transfer is must in a patient with CVD. Coming to the anticoagulation challenges, we know supraphysiological estradiol levels, which are associated with exogenous gonadotropin use, can provoke thromboembolism in the patients with underlying cardiovascular diseases, or mainly in patients with mechanical valves, arrhythmias, already having a history of thromboembolism, anticoagulation is must. So with oocyte stimulation and retrieval, LMWH is a preferred choice, and bridging strategies are required and around the retrieval. So this paper suggests how do we do anticoagulation bridging. The patients who are already on prophylactic LMWH, the last dose should be given 12 to 24 hours before pickup. It should be started 6 to 12 hours after retrieval, and 2 weeks minimum it should be continued. The monitoring is to be done with anti-factor 10A assays. But if the patient is on therapeutic LMWH or warfarin or direct oral anticoagulants, we have to switch to LMWH if possible. But if the patient shifting to LMWH is not possible, we should give her IV heparin around the time of retrieval. But on the day of pickup, we need a short period of anticoagulation because in this, there is high risk of bleeding if the patient is on anticoagulant. Coming to anesthesia and procedural consideration, oocyte retrieval requires careful planning. Pre-anesthetic checkup is must for these patients. It should always be done in a hospital-based OT with telemetry available for WHO class 2+, and we should have an ICU in place. Escalation plan should also be formed beforehand with cardiac anesthesia support. Coming to embryo transfer, single embryo transfer is strongly recommended. Frozen cycles are preferred over fresh transfer because it reduces the risk of OHSS and thromboembolism. It says that we should prefer natural or modified natural cycle. But if we are using a programmed cycle, transdermal and vaginal administration of estrogen is recommended to lower the risk of thromboembolism. Routine luteal support is acceptable because progesterone does not increase the risk of VTE. So coming to some genetic considerations, inherited cardiac conditions may be transmitted. So we should offer PGT-M when the mutation is known. So how should we guess that the patient can have a genetic transmission? We can either the patient will know, or if the patient is not knowing, we can ask about family history of sudden cardiac deaths, aneurysm, cardiac surgeries, or cardiovascular diseases at young age. In that case, genetic counseling is essential. And if we are having any doubt, so PGT-M should be offered. So these are all the conditions the tables show in which PGT-M should be considered, which mainly involves aortopathies like bicuspid aortic valve and thoracic artery aortic aneurysm, Ehlers-Danlos syndrome along with and Marfan syndrome, channelopathies like Brugada syndrome, CPVT, familial atrial fibrillation, long QT syndrome, cardiomyopathies, which we usually see like dilated cardiomyopathy, familial hypertrophic cardiomyopathy, and genetic syndrome with variable cardiac conditions like DiGeorge syndrome, Noonan syndrome. In all these conditions, PGT-M should be considered. So this paper is basically based on these 5 studies, which classify the patients according to different classifications, and they generally classify the complications. Like in first 4 cases of OHSS were seen, and 4 cases had heart failure and arrhythmias. In second study, 1 case had volume overload after retrieval. In third study, 1 case had OHSS and 1 had syncopal episode. And in fifth study, 1 had hemoperitoneum on post-retrieval day 5 after restart of warfarin requiring exploratory laparotomy. But the drawbacks of these studies were all of them had less than 100 patients. All the types of cardiac diseases were lumped into the studies. There were no classification into different types of heart diseases. So what are the key takeaways from this paper? ART is feasible for many with CVD if carefully managed. Multidisciplinary care is critical for the patients with CVD, and risk stratification guides ART versus gestational carrier decision, which is very important for our patients. Thank you so much.
Should I thank her?
Yeah, I think
Yes.
yeah, we would welcome Dr. Shalu, and we would like to have your comments. Yeah.
Charu, it's a very nicely presented. Yes, we do. That says ki heart disease patients we can offer IVF, but as a IVF consultants, we should be very careful about these patients, and we should also look for risk factors in these patients because these patients may have PCOS, they may be also having diabetes, hypertension, obesity. So we need to look into those risk factors also for them.
Yes, ma'am.
We should be looking about all those risks because that also increases their chances of having deteriorating of the cardiovascular disease during the IVF. Secondly,
Yes,
the IVF during the IVF when we're planning, the protocol should be not to overstimulate. Too much stimulation should not be there in these patients. And rest, I think you have covered nicely, and it should be a multidisciplinary team where it is affordable, not like centers where it is only a single center where we're doing a pickup, and it should be in a bigger hospital setting where the cardiovascular surgeon and the ICUs should be available and they can take care during the IVF and after during the pregnancy also.
Yes, ma'am.
That is what I feel that's there. And we should make sure that before we plan the treatment, we should make sure that the risk factors should be dealt, the hypertension, the diabetes, the weight, everything should be fully controlled before we plan to take these patients.
Yes, ma'am.
Right, Charu?
Yes,
Yeah.
ma'am.
So very nicely summarized by Dr. Shalu and very, crisp presentation, Dr. Charu. Actually, I was a little surprised seeing the number of hyperstimulation in the studies. So these only 5 out of the, I think, Dr. Shalu, normally we don't see so many hyperstimulations. And in all these studies, they had nearly 4. Some people had 1 hyper OHSS patient and all. And in spite of their being using the antag with the agonist trigger. So that means we have to be a little more, I think, careful. I don't know why it's so much of OHSS patients were there in this particular because as it is with these sort of protocols, I think OHS has become a little, has gone
because
very,
now
very down.
these are like case studies. They say ki OHS is when we do a segmental approach with the antag and when you're giving an agonist. These are like
Yeah.
a case studies which have come. We had one. So I think we also presented one case study like this, ki OHS in a patient who had an antag and a decapeptyl trigger. So normally we don't see this if we manage these patients properly.
Yeah. So it is very, very very nicely presented right from the time that we choose the patient till the time the patient delivers. I mean, these patients need to be really a risk stratification needs to be done very
Yeah,
carefully.
yeah.
They need to be selected, and we have to talk to them about multiple visits, multidisciplinary approach.
Should
Termination time may be a preterm delivery in case anytime the nursery that we might need to, if we need to deliver them preterm, where they need to deliver, everything needs to be discussed. OCPs need to be avoided, and definitely a single embryo transfer, because we do not want a
multiple
twin pregnancy at any cost. So very nice, Dr. Charu. I think it was very short, very sweet, but a very nice revision of everything. And the way there are I think the classifications and the risks that they have that you said about the cardiopathy, the valvular part, and the fourth, the genetic part and everything. So it was very nicely covered.
And
Thank
I
you.
think the thing
Yes,
when they're
Dr. Shalu.
satisfied, we should have that chart with us so that when the patient comes to us, we should know, okay, these are the patients which we can take and these patients we cannot take. And
Yes.
there we need to evaluate and get a cardiovascular physician to be in the team to understand ki, yes, we should go ahead or cannot go ahead with them.
Yeah. So thank you so much. Over to Dr. Lakshmi so that we can go on to the next case.
Yes, thank you. So we have second article, which is on assisted hatching decreases pregnancy outcomes in vitrified donor oocyte. Both these articles are from Fertility Sterility of August 2025 editions. So to present this article, we have Ms. Lovely Tewatia. May I have her CV, please? Yeah. So she's a senior embryologist in Cloudnine, Faridabad. She has worked as a senior embryologist at Baby Science IVF clinics and embryologist at ART fertility clinics and at Nova IVF Center, Lucknow. She is skilled in embryo biopsy and in vitrification of oocytes, embryos, ovarian tissue, micro manipulation of gametes, denudation of oocytes, conventional IVF, embryo transfer, sperm freezing, surgical sperm sample preparation, semen sample preparation, semen analysis, and DNA fragmentation. So over to you, lovely Tewatia.
So today I would be presenting a paper which is assisted hatching decreases pregnancy outcomes in vitrified donor oocytes. This article was published in Fertility and Sterility in August 2025. This study was done by Amalia Nameth and et al. So the background is, as we all know, that donor oocytes have gained global acceptance as a highly successful treatment option for individuals with poor egg quality or the couples with same-sex male couples, and in the individuals or couples who are carriers for the high-risk genetic conditions. So the laboratory advancement in the process of oocyte cryopreservation have led to improved oocyte survival, similar fertilization, and live birth rates as when compared with the fresh cycles. But the concern is the process of oocyte vitrification, however, has the potential to thicken or harden the zona pellucida, so for which assisted hatching can be used to reduce zona pellucida thickness of vitrified oocytes, but it has shown variable results. So the objective is to evaluate the impact of assisted hatching on implantation and pregnancy outcomes in donor oocyte cycles using the vitrified oocytes. The study design and methodology is a retrospective cohort study of all donor oocyte recipient cycles from a specific donor egg bank. Only cases where a single blastocyst was transferred with additional blastocyst available for cryopreservation from the same warning cohort were included, and the donor age with 21 to 32 and BMI from 18 to 28 and with a good ovarian reserve were included in this study. And the blastocyst transfers, the single blastocyst which was transferred was of day 5 or day 6 and with a grade of BB or better. So the exclusion criteria for this study was the embryos resulting from the warm donor oocyte that was subsequently vitrified and then transferred at a later date were excluded, and the patient with multiple ETs, PGTA for aneuploidy, and severe male factors infertility were also excluded. All the embryos were on assisted hatching was done on all the embryos, mainly with the laser or mechanically. So the sample size of the study was 2,617 embryos, which were categorized into two categories. One was assisted hatching, in which we had 1,668, and another one was non-assisted hatching, in which we had 949 sample size. This study was also done on the sibling cohort, in which 505 instances were in the assisted hatching group that has a sibling lot in non-assisted hatching group. So the outcomes measured were biochemical pregnancy, clinical pregnancy, ongoing pregnancy, spontaneous abortion, monozygotic twinning. Results for the main cohort. If we look in this table number 1, we can find that the biochemical pregnancy rate was lower in the assisted hatching group at 72% compared with non-assisted hatching group at 76%. In this, the value was statistically significant also. Similarly, the clinical pregnancy rate was significantly decreased in assisted hatching group when compared to non-assisted hatching group. The ongoing pregnancy rate was also low in assisted hatching group compared to non-assisted hatching group, and these all three categories were statistically significant. The spontaneous abortion rate in assisted hatching group was higher than non-assisted hatching group, but the values were not statistically significant. The monozygotic twinning was similar in both the groups, but it was also not statistically significant. So the results, then a sub-analysis was also performed using limited available data of recipients' BMI and age at the time of the transfer. The average age of the recipient was 43 in assisted hatching group, and in non-assisted hatching, it was 44. The average BMI was 27 in assisted hatching and 25 in non-assisted hatching. So the outcomes were similar with the earlier results, with biochemical pregnancy, clinical pregnancy, and ongoing pregnancy overall high in non-assisted hatching group, but the sample size was very small and it was not also statistically significant. So the results in the sibling subgroup, the same comparative parameters were calculated in sibling subgroup with the results shown in table number 2. In the sibling oocyte subgroup analysis, there was no significant difference in biochemical pregnancy, per ET, clinical pregnancy rate, ongoing pregnancy rate, and number of spontaneous abortion rate, from which we cannot conclude anything. So for the discussion from this large cohort study, we have found decreased biochemical pregnancy, clinical, and sustained pregnancy rates with the use of assisted hatching. We have also found an increase in number of cycles resulting in spontaneous abortion with the use of assisted hatching, but this was not statistically significant. When these findings were not observed in sibling cohort, because when the same donor had oocyte used with the opposing technique with or without assisted hatching, there was not a statistical significant difference in clinical pregnancy, ongoing pregnancy, or spontaneous abortion rate. So the sibling oocyte group is more appropriate control for difference in oocyte quality. However, the number of embryos evaluated was very small in the sibling group. So this study conflicts with the earlier small studies. For example, a study done by Figueria et al. In 2012, they have found a higher implantation rate with assisted hatching, but no significant increase in biochemical pregnancy rate. Although their study was having very small sample size with 30 patients in each arm. So this study have certain strengths also. So it is a large multi-center data set in which 29 IART centers have been included, and the standardized donor pool as the oocytes were recruited from a same donor bank. The limitations of this study include the retrospective nature of the analysis and restricted information available in the database used. So we were limited in our ability to provide the live birth rate, as retrospectively we have only looked for ongoing pregnancy and clinical pregnancies, and as 29 centers were involved in this, so that may have different protocols and standing operating protocols. So in the conclusion, we concluded from this study that according to this study, sufficient data is present to to know that assisted hatching routinely occurs in these cycles, and could decline the pregnancy outcomes. And as we all know that donor oocytes are increases the cost of the patient, and adding of assisted hatching may increase unnecessary cost and lab time. So routine use of this should be assisted hatching should be reconsidered. Additional large-scale prospective randomized studies are needed to establish firm conclusion regarding the use of the assisted hatching in the population. Take-home message: assisted hatching does not improve and may worsen pregnancy outcomes, and the routine use in vitrified donor oocyte cycle should be avoided. Thank you.
Thank you for the presentation, Lovely. Lovely, I need to understand how they used one donor for two people.
No, ma'am. In the sibling cohort, they have used it.
So they have compared it with the sibling cohort only, no?
Yes, ma'am. They have done they have included two groups, one in which they have considered the sibling cohort and the main cohort.
And so one donor was used for two people.
Yes, ma'am.
So that means the patient profile in which we have used the embryo, we have the sperm factor, the uterine endometrium factors, have they taken it into consideration?
Ma'am, everything was excluded. Exclusion criteria had the uterine cavity with polyps or some other anomalies, and severe male factor was also excluded from this study.
Because that is one of the things, because in if one donor may be different for the different two patients, it will be different. The response may be different about the blastocyst formation. And what about the endometrial thickness?
Ma'am, they have not specified anything for the endometrium thickness. And secondly, for that, that's why we have due to these factors, we have not find any statistical difference in the sibling cohort also.
Okay. And what about your experience? You are using assisted hatching in your center?
We are like, ma'am, as this study is for the vitrified oocytes, so we are using very less vitrified oocytes in the self, as well as we are not using in the donor at all. And for the self, we are using very limited patients are there for which we are using the donor, that vitrified oocytes.
No, forget about the vitrified, but as such,
Yes,
do you find any advantage if you're using assisted hatching? Is there any particular thing you're using it for, any particular group, or you're not using? And
currently, we are not using, but if I had to use, I'll use for the patient in which I find that a blastocyst has been expanded. The ICM and trophecto are fully differentiated, but the zona thickening is there. So I'll just drill the zona so that the embryo could hatch and can result in implantation.
And then secondly, I need to understand, there is what is called as full thickening assisted hatching. Then it is a partial thickening assisted hatching,
Yes, ma'am.
and then it is a laser and then mechanical. Does
Mechanical.
laser and mechanical also has a difference?
Yes, ma'am. In the mechanical, we are not using the laser. So we are,
The difference in the hatching, the results.
ma'am, I have not went
Because
through any study which can compare both. But in this
because
study, they have not specified any difference.
they have taken both them together, the
Yes, ma'am.
mechanical
Mostly
as
they
well
have
as,
taken the laser, like 90% were with the laser assisted hatching.
and 10% with the mechanical. Because
Yes,
I think mechanical is now obsolete. Everybody goes with the laser only
yes,
because
ma'am.
they find it. Okay. So.
Yeah, thank you, Dr. Shalu, for your comments, and lovely. It was lovely presentation, very nice. But
Yeah.
what exactly could be the reason why assisted hatching is decreasing the rates rather than increasing? And there was this one study of 2012 which had a contradictory result where
Yeah.
they expected getting more better pregnancy rates with assisted hatching, because anyhow when we have with actually it is a study which is a little unique because it has used vitrified donor oocytes and not the embryos that we are talking of. So
Yes,
we are here talking of the donor oocytes, and that too again there was it was used on two patients, one from one donor. I think it was used over two
Two patients,
particular
yeah.
participants.
two
Yeah.
groups were there.
So one is that, and where in India, where it would not by our
Right.
law, it is not allowed. So we cannot do such sort of study. Though we are just discussing a paper, it is not that we are talking of our case scenarios here. But that's, I mean, why it should have a negative effect rather than promoting? So what could be the reason? I mean, you being an embryologist, see, we are all clinicians here. Dr. Shalu is a clinician, Dr. Lakshmi and all. So in fact, now I feel we should have had more embryologists also, so that
In
we
this
could have
session, yeah.
taken their sort of perspective, and they could have explained to us. But since you are here, whatever you can understand, if you can share with us.
Sure, ma'am. So according to me, if we compare the study for that 2012, so in that it has they have in this study, the paper which I have presented, we have included only the SCT, the single embryo transfer. But in that 2012 study, they have used double embryo transfer. So that could also be the reason. And secondly, their sample size was very small. They had only 30 patients in per group. Here we are having 1,000 patients in one group. So that also might be because as the patient pool increases, the results might be contradictory with each other. And for the second thing, why it is showing that decline pregnancy rates in that main cohort, because it might be associated with the damaged that damaged might be the reason, because when we put the laser for the assisted hatching, some cells might also get degenerate, because if the cells are fully attached to the zona pellucida, so we are not having any gap, so that might also be a reason for it. And according to me, that's all, ma'am.
Yeah.
Even we can just say in 2012, the embryo culture and the environment was much different than what we have now.
Right.
Yes, ma'am.
This can be also one of the reasons. And there we were in 2012, we were more into the cleavage transferring, and now we are more into the blastocyst transfer.
Yes, ma'am. It was a cleavage transfer also at 2012. It was cleavage stage transfers.
So these can be the factors which can be little affecting the things.
Yeah. So I think there is a lot because 2012 and this study is the present one. So I think over 12 years, the things, the lab conditions, the culture media, and so many other things, our technology has markedly changed over last 10 years, 12 years. So those could be the reasons. And moreover, I think there we might need to have more papers on this particular donor oocyte, frozen donor oocyte, where they have done assisted hatching, where how the results are. And about the
Pardon?
embryos, about the embryo assisted hatching, Lovely, where do you recommend doing that?
In general, in particular cases where we cannot see any zona thinning, because as we all know, as the embryo expands, the zona thinning should be there. But if the oocytes are having thick zona or dark zona, so we can try laser assisted hatching at the time of the embryo transfer. And for the patient with recurrent implantation failure, it can also add a benefit for them, because we are hatching the embryo, so we are sure that the embryo has been hatched. And then if the patient still comes negative, we can look for the other factors also.
Right. So, Dr. Lakshmi, yeah, since I think we are done with the questions also, there was a question by Dr. Yukti, the same thing, why the pregnancy rates have fallen. So everybody is just, I mean, why instead of we expected to maybe increase our rates, but it decreased. So that was a little.
Actually, this paper was a little, the title itself is very
Yeah.
different, and we were
It is
expecting
different.
that.
That is why we took it. That
Yes.
is why you suggested that we should discuss this. That
Right.
why the rates are.
Now before asking for patients going for assisted hatching, we'll think twice. And if patient would demand on himself that we want hatching, then we can always counsel them that in recent studies we have seen that there is no added advantage for assisted hatching than if we go without hatching. So what do you think, Shalu ma'am? What is your
But I think this is for the
clinical-
donor egg. Let's not think
Oocytes.
about, because there we have patients who have got a lot of recurrent implantation failure using. This is for this donor. Let's not
Yes.
extrapolate into a patient's.
No.
Doing the self-egg.
That's why I was asking you, what is your experience with hatching? Do you routinely prescribe patients hatching?
No, I don't prescribe patients, because hatching is again a very gray zone. Some
Yes.
people say ki it is there, we should do it. But as Lovely has said, ki we should always look into whether the zona is thinning or not at the time when we're planning to do a transfer. Then only we should think we should be offered or should not be offered. That is the time the call should be taken.
Yes.
Rather than
Ideally,
doing
the
it,
embryologist
should be the one person involved taking the call, looking at it, because
Right.
they are the ones who keep on looking at the embryo, and they have kind of a gut feeling, or when they see it, they understand ki yes, this might be the one, they will help and they will not be.
Right. Definitely.
Yeah, and could the advanced age maybe the indication for a hatching? Because there we might expect a little hardening
Hardening of the zone.
So, right. So, yeah, Yukti has suggested that could the reason of lower pregnancy be the use of vitrified oocytes? So, I think we can't say anything much about this paper, but it was just a good for the discussion. We had kept it, and I think we still cannot make our conclusions based on such papers. So it is just a food for thought, and maybe that is something, that is why we discussed it.
So we need still more papers to go for.
Right, yeah.
Yes.
Yeah. So thank you so much. Thank you, Dr. Shalu, for your comments and the nice presentations that we had from Dr. Charu and Lovely. And thank you, everybody. Thank you, Dr. Lakshmi, for being the MOC. And
Thank you.
so I think again we meet after a month or so for another discussion. And over to Nimisha for the conclusion.
Thank you, Dr. Jyoti. Thank you, Charu. And thank you, Lovely and Lakshmi. Bye. Thank you.
Thank you, ma'am. Thank you so much for coming and taking out time. Thank you, ma'am.
So thank you for joining in today. The session was today brought to you by Jackson Pal, makers of Cystidia M, Tewatia SR, and Lycorate M. So once again, thank you everyone and have a great day.
Yeah, I would like to thank all the participants as well. We had good number of participants today, and I am sure they must have enjoyed it a lot. So thank you all the participants who were there with us today. Thank you. Thank you, Nimisha and Lycorate. Thank you, everybody. Bye-bye.